Welcome to the Center of Excellence for Behavioral Health and Nursing Facilities podcast called Better Mental Wellbeing. I am your host, Dr. Diane Sanders Cepeda. This is a compelling series that delves into the profound and diverse stories of individuals navigating the intricate landscape of behavioral health and substance abuse. This episode was produced in collaboration with the Post-Acute and Long-Term Care Medical Association, also known as PALTMed. Today, we welcome our special guests, Dr. Singh Pallet and Tanya Witt. I'm very excited to be talking about easing transitions of care for patients with serious mental illness. If you are tuning in, you will recall a wonderful discussion that occurred around the challenges we see with transitions across the post-acute long-term care continuum for individuals with serious mental illness. I am joined by Tanya Witt and Dr. Singh Pallet, and I will give them a moment to introduce themselves. Tanya, we can start with you.
Hello, everyone. My name is Tana Witt. I am a psychiatric mental health nurse practitioner and the Chief Operating Officer for Mind Care Solutions. Excited to be here today.
Nice to see you again, Tana. I'm Singh Pallet. I'm a geriatrics physician and medical director here in Denver, Colorado. I'm the market medical director for Optum Senior Community Care.
And to everyone listening, I am Dr. Diane Sanders Cepeda. I am very excited to be here. And I want to start with you, Singh. I want to just, we went through that wonderful presentation, and I just want us to revisit a couple of the things that were really hot topics. So can we start with discussing the common challenges that we see for patients with serious mental illness when they're being discharged from the hospital to the nursing home?
When people are transitioning from one place to another, there are always challenges. And for people who have serious mental illness, those challenges are just magnified. When someone's coming from an acute setting to a post-acute or long-term care setting, we need to make sure that there's going to be a seamless transition of their care. And that means that the information has to come over with them. That means any resources that are necessary for their care come along with them. And that means a whole set of expectations and knowledge that needs to be in place from one place to the other comes with that patient. And for people who have serious mental illness, sometimes that knowledge and that information is highly specialized. And if any piece of it gets dropped, that person can have some serious consequences. So we look at it from all aspects. How are we making sure that the information gets over? How are we making sure all the paperwork is in line? There's a special document, the PASSAR, that has to come with people that has very specific information that outlines their care plan. And how do we make sure, too? We want to make sure that the transition involves the expectation that any follow-up care, any appointments, any names of providers, phone numbers, that all that is transferred at the same time as the transition.
And Tanya, can you speak to what technology we need to have in place so that we can do this better?
Yeah, I think with the transitions of care and just in general with electronic health records, a lot of our systems may speak to each other, but they don't necessarily speak to other systems. So when we're looking at readmitting a patient to a nursing facility or admitting a new patient to a nursing facility, we have a checklist of what information we want to make sure comes with them. A lot of times that information is not coming over seamlessly from the electronic health record to the electronic health record at the nursing facility. So it's pertinent to make sure that we're requesting those documents and then uploading them for the entire interdisciplinary care team to be able to see. Ideally, those records could transfer from systems to system, but we know that that's not the case. A lot of electronic health records are working on that interoperability. I know Epic is looking at some of the options for them to be able to transfer records to other systems that work within long-term care communities like Point Click Care or Matrix or any other system, but it's not typically there. So I always recommend that the facilities look at what they need and then ensure that they're getting that information and then reaching out if they're not. So, calling the hospital and saying, hey, we're missing the H&P. we're missing the medication list, or we're missing, the notes in between to figure out what occurred between their admission and their discharge that might give us the information that we need to make the decision.
I'm curious, besides the PASSAR, are there any other regulatory challenges or mandated things that must come over from the hospital?
Well, the PASSAR you mentioned is mandated, you're right. And that's the document. It's a tool that allows the acute facility to screen a patient, outline what their diagnoses are, get someone with some mental health background and expertise to write out some care plan that should go with that person to the next facility. And that is crucial to have in place, both for ensuring that the patient's care is carried out in the recommended manner, but also for compliance for the facility, and ensures that they get paid the right way. Other than that, I don't know of regulations that say exactly what information has to go with a patient. We are mandated to have transfers that involve good transitional care. We are required to transfer necessary medical information, but kind of beyond that, it's up to how the providers and the systems have set it up. Ideally, Tana used the word ideally. We always want the ideal situation. We do need that patient's recent record of all the events that have happened, what happened when they were in the hospital, or what happened when they were in the skilled facility before they go on to the next setting. We want to have an accurate list of diagnoses. We want a medication list that is up to date with all the right details, as well as some explanations of any recent changes. We would like to have a list of their upcoming follow-ups, their upcoming appointments, and who to call if there's a problem. Who's their main psychiatry provider if we don't have that information in the record. And as with any good medical document that outlines the patient's health, we want to know the patient's goals of care as well. And we don't want to assume that just because we have someone who has a serious mental illness, that perhaps they have a certain goal of care. We have to ask them to have that discussion. That information has to transfer over too.
So I'm curious, and Tanya, maybe you can walk me through. Now we've transferred this person with serious mental illness from the hospital. They're in our post-acute long-term care facility. In thinking about the best practices we should be adopting, can you walk us through what we should be seeing once we're there in the facility?
Yeah, so when admitting a patient to a nursing facility that has a serious mental illness, identifying the treatment team that's going to be required to care for that patient is very important. Looking at making individualized treatment plans for the patient within the facility. Who are we going to be able to refer that patient to? Is there a psychiatric provider that can see that patient? Is there a psychology team that can come in and help support that patient, case management, social work, and then, ensuring that the interdisciplinary care team is working together to make sure that we are completing everything as part of their care plan. Multidisciplinary team approach is the most important. Most of their medication treatment plans are comprehensive. And so ensuring that the staff is aware of everything that they need to look for with that, adverse effects, making sure that they're taking it, reporting when they're not taking it, all of those things are important. So I think when they come into the building, it's crucial for us to be able to sit down and come up with that plan of care for the individual and really individualize their treatment plan in general so that everyone's taking care of them.
Thank you. I'm curious because in my experiences, it always felt like there was a who's on first kind of phenomenon happening. So how does that multidisciplinary team, the primary care team, the nursing staff, the mental health specialists, how should they be collaborating? And seeing, I'm going to toss it to you to see if you can maybe start off and just what do you think? How should we be collaborating?
And that's a really key question for these transitions of care, because often the teams involve more people than just a core group of people that we might be used to working with. So during a transition of care, someone might be coming from one setting and going to another. So there are two teams that have to collaborate. There can't be some ego or someone who thinks they're right and the other one's wrong. That collaboration has to be there between settings, and often that's a big challenge. Even within the setting, like you said, if the patient is already in the skilled nursing facility or long-term care facility, we're dealing with people on the medical team, people on the nursing team, people on the mental health or behavioral health team, and all of those aspects are crucial to the patient's care. We might want to have a driver of that care, and in each team there might be a different person who's designated as such. Often, if you're lucky to have a care coordinator or a case manager, that can be a coordinator or a central person. It could be someone from the primary care provider team. The behavioral health team has to be involved with all aspects of the care. We can't be treating the patient's medical conditions and think that behavioral health is just on the sidelines. And it can't be the other way around either. I always talk to my teams about communication, make sure that we're not making assumptions, make sure that we're not just communicating via the medical record. If there's some other way to communicate, like with a telephone call, through set up meetings, or even non-scheduled meetings. If you see one of your consultants in the hallway, take a moment to stop and chat with them. Talk about the patient. Make sure that we're aligned in how we're treating them and that any other information that's not just in the medical record is conveyed, and everyone has to be working together.
And that's a really good point. As an organization, we do have some facilities that have a really high serious mental illness population. And so we work very collaboratively with primary care. And when patients are admitted, if they're taking psychotropics, we're actually called as part of that admission as well. So we'll see the patient right away, we'll review their psychiatric medications, and then we'll kind of reconcile that against what, records we do have for the patient. If they came back to the facility or if they are a new admission to the facility, we'll look and see if we're going to continue those medications and then set up a plan of care in regards to when we're going to see them again in the building. So some of the facilities that have this really high serious mental illness population, that's just standard. The psych team comes in and sees the patient within so many days of their admission instead of waiting until the next time they're in the building, so that we can get that care established right away and really start collaborating.
That makes a lot of sense, and I think that that sounds like a best practice. I'm curious, can you explain how you incorporate the non-pharmacological techniques into managing someone who has serious mental illness in this space?
Yeah, I could start. I think, when you get a new patient, it takes a little while to understand what non-pharmacological interventions will work for them. But generally, practicing non-pharmacological interventions before pharmacological interventions is the most important for our organization and just in general in mental illness. I think making sure that the people caring for the patients have a general idea of basic non-pharmacological approaches, especially in regards to like escalations or crisis, and just de-escalating patient behaviors, communicating appropriately is always very important. And then, like any part of the treatment plan, tailoring those non-pharmacological interventions to the specific patient as to, what their triggers are, and what has worked or, can potentially work in the future is really important.
Let me ask, because I'm walking through this journey with this patient who I have in my mind who has serious mental illness. How do we get to the point where now they're in the post-acute facility, we need to transition them back to the community? Can you talk us about what does that transition plan need to look like?
Yes, and we would hope that anyone who wants to go back to the community gets the chance to do that. Just before we move to that section, you had asked Diane before about regulatory challenges, and we talked about how the PASSAR is a very important part of this transition. But another piece of that is just how special the long-term care regulatory environment is. So before this person moves to the community, I just wanted to address that. We know that people living in long-term care or staying in a skilled nursing facility, even if it's for a short stay, are under heavily regulated scrutiny from surveyors. And that means that sometimes the choice of the antipsychotic that is chosen, sometimes the diagnosis that is associated with an antidepressant, the duration, the frequency, the specific way that a PRN order is written in the chart is very, very important for regulation. And as people go from one setting to the other, sometimes a little bit of that gets lost. And it's really important that the people who know how to prescribe the right way and manage the medications the right way are the ones who are handling that.
And
So
yeah,
if
that's a good point too. I was going to say, part of that initial evaluation I was talking about when a patient's admitted is reconciling all of that. So it's looking at their diagnosis. Sometimes patients come into the nursing facility and they have multiple psychiatric diagnoses, and that's part of this record that kind of continues to follow them. So digging into the information and trying to figure out what the patient really has. I mean, a patient can come to a skilled nursing facility and they can have, 10 mental illness diagnoses that haven't fallen off their record. But then when you dig into the actual notes from the hospital or from the psychiatrist that saw the patient at the hospital, they're treating them for one diagnosis or two diagnoses. And so you can kind of tailor those down and get the facilities the appropriate information so we can remove diagnoses that might not be accurate, to be in alignment with the CMS regulations. And then, like you had mentioned, sometimes they come in with PRN medications for antipsychotics. Those need to be evaluated and have a stop date associated with them. So just looking at everything from start to finish and making sure they're in compliance, but also that the patient has a care plan in place until, psychiatry can come back, and contribute again to the care plan is important as well.
Yeah, that reinforces the reason why we need to be a strong collaboration, especially when you, as maybe you're the medical director or the attending physician, on this person's case, and you're getting a recommendation to taper off of a medication. I really need to make sure I'm connecting back with the specialists, the behavioral health, mental health specialists who are helping manage that individual. So, getting back to the other question, if I'm going to now try to get this person ready to go into back to the community, or and seeing you brought this up, staying in the building, what do I need to do for any one of those scenarios?
When someone transfers to any setting of care, just like we talked from the hospital to a long-term care or SNF setting, that transfer, we want it to be seamless. We want it to be very safe for the patient. When we're going to a community setting, which has a very different set of constructs and models of care, there are additional things we have to think about. In addition to having the best medical records possible, the ideal body of information that travels with the patient, we also have to do the supports, make sure that our patient is educated and knows about their own diagnosis and can advocate for themselves, whatever care needs that they're going to need to be able to manage their health and their medications. We're going to spend that time while they're in our care educating and empowering them to know how to watch for medications, knowing how to watch for their own symptoms, knowing how to call a provider and who to call when it's needed. Sometimes it's their caregivers that need that support. Sometimes it's a PT or OT that needs to be involved to help making sure that they're able to function. And when they are out of the care of the long-term care or SNF, the new treatment team might be an outpatient clinic. They might be in different locations with medical care in one building and mental health care in a different building. There could be some caseworkers involved. There could be people who are helping them in their homes. We want to make sure to get them plugged back into all of those support systems and have a way for the whole team to know that body of information we've been putting together about them.
Thank
Yeah,
you.
and I think too, one of the biggest things to look at with transitions of care is that support when they're discharged back to the community. And a lot of times, depending on where you're located, but in general, there can be a long wait to get a patient in with a psychiatry provider, even if they've already had services established prior to being admitted. There are some transition of care programs or organizations that actually provide services for transition of care. And so what they do is they follow the patient very quickly after they're discharged via telehealth typically, and they ensure that they meet with a social worker, sometimes a health coach, a nurse, psychologist, LCSW, and then also a psychiatrist to ensure that their medications, or psychiatric provider, to ensure that their medications are, prescribed appropriately. They have those touch points if they need any changes to that prescription until they can get into that inpatient or in-person, not inpatient, visit with an established person that they can continue to follow in the community. What they're able to see with those is that they're able to prevent readmission back to the facility or back to the hospital if they were there for a short stay because of a hospitalization. And so I think part of it is really ensuring that you're able to get that follow-up treatment so that they have that support system when they're discharged.
Yeah, I thank you for that, Tanya. Because that was going to be my final question to you. Like, what do we do in those situations? If somebody is, thinking about how the diversity of the audience who's out there listening to us, providers, administrators, directors of nursing, other mental health specialists, ancillary services, if someone is trying to figure out this for that individual, um, who should be their first step in looking at the resource? Like, how can we get that partnership so that we know who they're going to be transitioned to when they go to the community?
So typically in my experience, the social work team at the facility is usually the ones coordinating that. And depending on where you're at, the resources can be limited. If you have a psychiatric provider, I would always say ask them where the resources are and what they know about. I know our organization always tries to help support that in regards to calling different, community places that they may go. But yeah, typically it's the social worker, at least in my opinion.
So I'm really grateful again for this conversation. Seeing Tanya, any final thoughts, any closing comments that you want to make to everyone who's listening?
Well, if you caught the panel discussion, the webinar, it was called Gentler Journeys. I just want to remind everyone that when patients, residents, when people are transferring from one setting to another, often that big change is related to some medical event that can be very traumatic. The transition itself can be very traumatic. And layer on top of that serious mental illness, we need to be very empathetic and very sensitive to the needs of our patients as they're making these journeys from one healthcare setting to another.
And I would just add, everything in transitions or taking care of a patient takes time, but sometimes taking the time in the beginning to get the right information, regardless of how it comes to you, can make a difference in that patient's care. If you're missing some of the information from the medical record or from their stay, or you're missing the information going to where they're being discharged, it can cause a lot of issues for the patient that can result in poorer outcomes. And so stopping and being able to know what you need and then figuring out a way to get it for those patients can make a huge difference in their quality of care, regardless of where they're transitioning from.
I thank you both, and I hope everyone listening will take the time and really help to make this a gentle journey for those individuals who are challenged with serious mental illness. Thank you, and have a great day to everyone who's listening.